Hello, my name is Kieran Doherty and this is an educational presentation looking at the brachial plexus. In this presentation, we will be demonstrating how to produce a simple diagram of the brachial plexus, explain the function of the nerves of the brachial plexus, and finally we will examine some of the common fractures of the upper limb. Many of you will have seen this or similar diagrams of the brachial plexus. My goal is to show you how to turn this into this. And to do this, all you need to do is remember Y, W, X, Z and 3. We begin our drawing with our first Y at the top of the screen. We follow this up with our second Y at the bottom of the screen. Our third Y runs in the opposite direction in the middle. We connect our top and bottom Y with a W. For orientation purposes, I like to add in the nerve roots of the brachial plexus C5 through to T1, as I will now demonstrate. Our next letter to be added in is our X, which joins our top Y with our middle Y. We then add in our Z to connect our middle and bottom Y. As you can now see, I am now labelling what I consider to be the major nerves of the brachial plexus. Finally, we need to just add in our 3's, and this is done by drawing 3 lines on each level of the brachial plexus and joining the first 3 nerve roots together. In this diagram, each line represents a specific nerve. Which is represented in this diagram. And now you can see how you can create a simple diagram of the brachial plexus using Y, W, X, Z and 3. Now we will review the muscles which are innervated by the nerves. Additionally, we will look at the actions and functions these muscles control. We will begin with the first nerve identified, which was the long thoracic nerve. This nerve innervates the serratus anterior muscles. Injury to this nerve clinically will cause winging of the scapula, which is demonstrated in this image. Next, we will look at the dorsal scapular nerve. This innervates the levator scapulae, the rhomboids major and the rhomboids minor muscles. Next, we look at the suprascapular nerve. The suprascapular nerve innervates the supraspinatus muscle, the infraspinatus muscle. The supraspinatus muscle is clinically significant as it produces the first 15 degrees of abduction of the shoulder. Injury to this nerve or its muscles, such as that which occurs in impingement, will cause the patient to have difficulties initiating abduction of the shoulder. Next, we will look at the lateral pectoral nerve. The lateral pectoral nerve innervates the pectoralis major muscles. The functions of this muscle can be remembered with the mnemonic family. If you remember that we like to hug our family, and this is the action of the pectoralis major muscles, it enables flexion, adduction and medial rotation of the humerus. We will now look at the upper scapular nerve. The upper scapular nerve innervates the suprascapularis muscles. This nerve has no clinical significance and thus we will move on. We will now look at the thoracodorsal nerve. The thoracodorsal nerve innervates the latimus dorsi muscle. The latimus dorsi muscle's function can be remembered by the acronym MIL, as the functions are medial rotation, extension, adduction of the humerus, and these are all controlled by the lats muscle. Next, we will look at the lower subscapular nerve. The lower subscapular nerve innervates the subscapularis and anterior major muscles. Similar to the upper subscapular nerve, there is little to no clinical significance of this nerve and thus we should move on. The next nerve is the medial pectoral nerve. The medial pectoral nerve innervates the pectoralis major as well as the pectoralis minor. Next we will look at the medial brachial cutaneous nerve. The medial brachial cutaneous nerve, in addition to the medial antebrachial cutaneous nerve, is what I call a Ronseal job, as it does exactly what it says in the tin, and thus I will quickly skip over these and move on to the musculocutaneous nerve. The muscles innervated by the musculocutaneous nerve can be remembered by the acronym BBC, which stands for the biceps brachii, the brachialis muscle, and the coracobrachialis. Next we will look at the axillary nerve. The axillary nerve innervates the deltoid as well as the teres minor. The deltoid muscle is clinically significant as it allows for abduction of the shoulder between 15 and 90 degrees. Those patients that are complaining of injury to the axillary nerve or the deltoid muscle will have problems with abducting their arm past 15 degrees. Our next nerve is the median nerve. The median nerve innervates the flexors of the forearm except for the flexor carpi ulnaris. In addition to this, it also innervates some of the muscles of the hand, which may be remembered by the acronym LOAF, which stands for the lateral two lumbricals, the opponens pollicis brevis, abductor pollicis brevis, and flexor pollicis brevis. Next we will look at the radial nerve, and in my opinion this is the best nerve. And the reason I say this is because the acronym BEST stands for the brachioradialis, the extensors of the hand, the supinator muscle, as well as the triceps. Injury to this nerve commonly causes the patient to have wrist drop. Finally, we will look at the ulnar nerve. The ulnar nerve innervates the hypothenar eminence. The hypothenar eminence contains the medial two lumbricals, the palmar and dorsal interosseous muscles, as well as the adductor pollicis. Now we will look at the 5 most common fractures of the upper limb. These include clavicular fractures, proximal humeral fractures, humeral shaft fractures, fractures that involve the distal humerus and distal radius. We will begin with clavicular fractures. These account for approximately 5 to 10% of all fractures. Their typical mechanism of injury is that of a direct blow or a fall in outstretched hands. In this fracture, the medial fragment is likely to displace posterior-superiorly due to the action of the sternocleidomastoid and the trapezium muscle. The lateral fragment is likely to be displaced inferior-medially due to the action of the pectoralis major and gravidae. These fractures are associated with ipsilateral scapular fractures, scapulothoracic dissociations, rib fractures, and pneumothoraxes, as well as vascular compromise. In addition to this, there is also neurological injury. Neurological complications of this fracture can present as a late sign, and these can be caused by hypertrophic callus formation, non-union or subclavian pseudoaneurysms, which cause compression of the posterior cord of the brachial plexus and affects the upper scapular and lower subscapular nerves as well as the thoracodorsal, axillary and radial nerve. Next we will look at fractures involving the proximal humerus. These fractures account for approximately 4 to 6% of all fractures. Their mechanism of injury may be divided into low energy, which are common amongst the elderly, and high energy, as caused by road traffic accidents, which are more common amongst the younger population. Fractures of the proximal humerus are likely to occur through the greater or lesser tuberosities or through the surgical neck of the humerus. These fractures are associated with vascular injuries, most commonly the anterior and posterior circumflex artery, due to their close relation to the surgical neck. Also displacement of the greater or lesser tuberosity. In addition, these fractures are also associated with neurological complications. These complications are due to injury of the axillary nerve due to its close relationship with the surgical neck of the humerus. Next we will look at the fractures involving the humeral shaft or diaphysis. These fractures account for 3 to 5% of all fractures, and their mechanism of injury can be divided up into low and high energy. As before, elderly patients are more susceptible to low energy injury. These fractures are associated with injuries to the deep brachial artery. In addition to this, they are susceptible to neurological complications. These complications are due to the injury to the radial nerve because of its close relationship with the spiral groove of the humerus. In specific situations, this injury may be known as a Holstein-Lewis fracture. Next, we will look at fractures of the distal humerus. Fractures of the distal humerus are most common amongst young males and older females. As before, the mechanism of injury may be divided into low and high energy. They may be described as unicondylar, bicondylar, supracondylar, or intracondylar. These fractures are associated with elbow stiffness as well as neurological complications. These complications are most common when the fracture affects the medial epicondyle. This is because of the anatomical position of the ulnar nerve in relation to the medial epicondyle, making it likely to be injured in a fracture affecting this. Finally, we will look at fractures affecting the distal radius. These are defined as being the most common fracture. As before, the mechanism of injury may be classified as low or high energy. These fractures have many eponymous names, such as die punch, Bartons, chauffeurs, Coles, and Smiths. They are associated with rupture of the extensor pulsus longus tendon, compartment syndrome, and neurological complications. The most commonly affected nerve is the median nerve. This is because of the high incidence of carpal tunnel syndrome associated with these fractures. Additionally, the ulnar nerve may be damaged in distal radial ulnar joint injuries. This is a copy of the textbooks I used in the production of this teaching presentation. Thank you very much for watching.